from Manipal College of Allied Sciences, Manipal, and sir has done his PhD from Mangalore University in 2012. And sir has been trained under many faculties like Loma Linda University, USA, Orthopedic Medicine International, Belgium, then University of Queensland, Australia, the Chartered Society of Physiotherapists, UK, and British College of Osteopathic Medicine, London. And sir has trained more than 25,000 physiotherapists across the globe, both national and international. And sir is the organizing chairman for the 50th Golden Jubilee Conference of IAP, which was held at New Delhi in March 2012. And sir has also organized the first World Congress on Manual Therapy in 2007, which was held at Mangalore. And Mohanty sir has presented several research papers in manual therapy and at national and international level conferences. And sir has many publications in journals and newspapers. And sir is a visiting faculty at EduTrack physiotherapy events held at Dubai and several other institutions. And sir was elected as a president of Indian Association of Physiotherapists twice, first in 2012 to 14, and then 2014 to 17. And sir has taken several initiatives to improve the physiotherapy profession in India. And it is a great honor to introduce Dr. Umasankar Mohanty. And I now hand over the session to Mohanty sir.
Thank you, Dr. Venu and Dr. Nikita, our moderator. And I also appreciate the efforts of Dr. Apurv and Dr. Bibek Kulkarni sir also called me up regarding this same program. And I appreciate the initiative of OrthoTV and Sanchati Institute and all the staff members, especially Dr. Parag Sanchati and our senior Sanchati sir, all the staff members. I am indeed delighted to have this presentation about the ankle and foot dysfunction. Although the ankle and foot is so important that there is one exclusive professionals called as podiatrist who deal with the ankle and foot problems, but physiotherapists across the world, the sports physiotherapists, manipulative therapists, they deal the ankle and foot dysfunctions very effectively. And you know, when we read about one of the first steps, what we read in biomechanics, it's about the gait. And in the first part of the gait cycle, it starts with the heel strike. And that's how the foot is so important to make us move from various places and to ambulate, to do all the activities. Although, in this session, I'll be covering the practical demonstrations and about the ankle and foot dysfunctions. Foot has nearly 28 bones and 55 articulations. And you see, we'll be discussing first about the various ankle joint, the various bones participating in the ankle joint. And then we'll discuss about the subtalar joint, and then how to palpate for the tarsals, which is quite important, and how we can tackle for the flat foot. You know, many people will be having flat foot in the present times because you know, those who have a sedentary lifestyle and who rarely work with barefoot and who rarely do the foot exercises. You know, that is quite common. Flat foot I see often in the clinic about flat foot, plantar fasciitis. So those how we can apply the manual therapy techniques, and some of the tapping techniques also I'm going to cover. So I'm quite hopeful that the session will be informative and useful to all those people who are watching now and then who all will be watching afterwards. So to help me out, I have two of my staffs, Dr. Basu and Dr. Ani. They will be helping me so that I can present my talk in a more appropriate and practical way. So this is the ankle joint, which is comprising of the inferior part of the tibia and the fibula and the talus. This is the ankle mortise. And here, and that the inferior part of the tibia and the fibula, it is concave and the talus is convex. And in manual therapy, the convex concave rule is extremely important. And here, another important thing is the anterior part of the talus is more wider and the posterior part of the talus is narrow. So the foot is more stable in dorsiflexion and foot is unstable in plantar flexion. Why? Because the anterior part of the talus is more wider. So you can see the maximum weight in the foot is transferring, and I just mentioned about the heel strike, foot flat, and then mid stance position. In the mid stance position, you see the anterior wider part is coming in contact with the inferior part of the tibia and the fibula, that is ankle mortise. So the foot is more stable, and the foot is unstable in plantar flexion and inversion. And that's why we find the majority of the ankle injuries, ligamentous injuries, happening in plantar flexion and inversion position because the foot is unstable. So I'll show the techniques now. And what are the for ankle joint? We have the dorsiflexion and plantar flexion. And as I just mentioned, the anterior part of the talus is more wider. So before, suppose somebody comes with some stiffness of the ankle, we need to mobilize the inferior tibiofibular joint. So what are the various mobilizing techniques we have there? We have the epiglide for the inferior tibiofibular joint, PA glide, and cephalic glide and caudate glide. Because if there is some, it has to have a selective opening because the anterior part of the talus is more wider. So when there is stiffness, and especially suppose we want to do the dorsiflexion, we need to mobilize the inferior tibiofibular joint at first, and then next we will go for anterior to posterior glide. Because for dorsiflexion, the convex surface is moving with respect to concave, and for dorsiflexion, we need to apply epiglide for the ankle joint, and for plantar flexion, we need to apply the posterior to anterior glide for the ankle joint. So right now, what I'll be doing is I'll be demonstrating on the model. I just explained the various articulating surfaces and the various movements. And yes, please lie down. Okay, just right. Okay. So we need to stabilize. We need to put one pillow below the knee so that for any foot mobilizations, yes, we need to keep the knee in flexion position because so that the gastrosoleus is relaxed. Because if there is gastrosoleus tension, so that is going to create some hindrance for us to do the mobilization. So first is epiglide. You can see here placing the pulp of the thumb anterior to the I'll do for just come this side. I'll do for the right side since I'm having the skeleton for the yes right side. So I'll be demonstrating for the right side. Okay, right. You can see here. So we'll be mobilizing for the inferior tibiofibular joint first. That is the fibular inferior part of the fibula and giving the anterior to posterior glide. So you see here the knee is flexed, pulp of the thumb anterior to the lateral malleolus, and I'm giving the anterior to posterior glide. See the grade 1, 2, 3, 4. I would like to add one very important information that in the ankle joint, the lateral ligament injuries are very common. And in the lateral ligament, the ATFL. So there is a technique in when there is lateral ligamentous injury, we have to give a glide to this, not exactly anterior to posterior, but we have to give because in that case, the lateral malleolus comes anterior and inferior. The lateral malleolus translates anterior and inferior in case of lateral ligament injury, and so that we can give the glide posterior and superior to correct that. So right now we are discussing about the epiglide. Just one more additional information I just said. So epiglide and cephalic glide, we can palpate the lateral malleolus. We can give a glide in the cephalic direction directly, or we can, if it is more sensitive, sometimes in the lateral ligament injury there will be swelling here, and in that case it may be more sensitive. So what we can do is we can take the foot for eversion. So when we take the foot for eversion, then there will be cephalic glide. Cephalic glide. Go to the barrier and give the grades. We are supposed to give the go to the physiological barrier, and this is the anatomical barrier, and we are supposed to give the grades, just before the resistance, and then we give the various grade 1, 2, 3. We can palpate, and that is cephalic glide. So we can give a direct technique, and if it is more sensitive, we can give the technique towards eversion. With eversion, there is cephalic glide. And with inversion, we can get the caudate glide. So grade 1, 2, 3, 4. So one is epiglide. So in supine lying, we can give 3 techniques: epiglide, cephalic glide 1, cephalic glide 2, and then the caudate glide. And for the posterior to anterior glide, we have to put the subject in the side lying position. Come to side lying position. Yes. Subject is in the side lying position, and then we can place the palm of the thumb posterior to the lateral malleolus, and we can give one translation posterior to anteriorly. So just I'm placing, we can give the translation this way, so posterior to anterior direction. And then come to supine lying position. So once we have mobilized for the inferior tibiofibular joint, then we can go for the ankle joint. In the ankle joint, we can give, I'll just show here, we can give the anterior to posterior glide to facilitate the dorsiflexion. We have to give the epiglide, and for plantar flexion, we have to apply the PA glide. So here, and the general rule of mobilization we have to follow, and the general rule is that the joint should be in the loose pack position. So what is the loose pack position of the ankle joint? It should be about 15 to 20 degrees of plantar flexion. So in plantar flex position, if I just before I am demonstrating here, I'll just explain once again with the skeleton so that it is more clear, the palpatory aspects and all. So for the ankle joint, we can stabilize the posterior aspect of both the malleoli, and from the anterior aspect of the talus, which is more wider, we are putting the first waist space and we are giving glide anterior to posterior. So that's about epiglide to facilitate the dorsiflexion, and we palpate posterior aspect of both the malleoli, and talus. Foot is in the slight plantar flex position, and we are giving the glide anterior to posterior. Epiglide. Epiglide is applied. Epiglide is applied to increase the dorsiflexion, because here the convex surface is moving with respect to concave. Now we see during dorsiflexion, if we just analyze, when a convex surface is moving with respect to concave, during dorsiflexion, say the foot is coming posterior to anteriorly, and so it will be opposite. It will be, that's how you can remember. So we can give the epiglide for dorsiflexion, and a priori to that, if we find that there is restriction of dorsiflexion, before we go ahead with the ankle mobilization of the talus, we need to mobilize the inferior tibiofibular joint, and just I explained what are the various gliding techniques we are going to apply: epiglide, PA glide, cephalic glide, and the caudate glide there. And as far as the ankle joint is concerned, we have the epiglide for facilitating the dorsiflexion range of motion, or to decrease the pain associated with dorsiflexion. And for plantar flexion restrictions or pain, we can give the posterior to anterior glide. For PA glide, we stabilize the anterior aspect of both the malleoli, and then from the posterior aspect of the talus, anterior aspect of both the malleoli are stabilized from the posterior aspect of the talus, giving posterior to anterior translation. You see, giving the various grades: grade 1, 2, 3, And what you can do is sometimes you can use the concept, basic concept, what was given by Brian Mulligan. You can maintain the glide and then ask the person to do the active movement. So what you can do to facilitate plantar flexion per se is that you can give a PA glide, stabilizing the anterior part of both the malleoli, and then giving posterior to anterior translation, and ask the person to do the plantar flexion. Do the plantar flexion, yes, take your foot down, right. And similarly, for dorsiflexion, along with the mobilization, afterwards you can give epi glide and ask the person to dorsiflex, right. So that's how we can give the glide and movement together. So definitely it will be helpful, and then only giving the glide also is quite helpful. You can give the glide first, and then afterwards you can facilitate the blending the or combining the accessory movement and the physiological movements together. So next, right. So I just explained to you about the ankle joint and the inferior tibiofibular joint. And next, I'll tell you about the uh, palpation of the subtalar joint. Next is the subtalar joint. Then I'll tell you, or we'll discuss about the how to palpate for the various tarsals, and then we'll go for the metatarsophalangeal joint. And while I'm discussing about the various subtalar joint techniques, I'll also discuss, what are the techniques which will be going to be more useful in case of flat foot, plantar fasciitis, and all. So coming to the hind foot is very important, because in the first part of the gait cycle, you see when the heel strike goes, the first joint which is taking the load is the hind foot, the subtalar joint, and this is the sustentaculum talli, where from the talus the load is transferring to the calcaneum. And what are the various glides we have here? We have the posterior to anterior glide, the PA glide. So for PA glide, we have to stabilize the anterior aspect of the talus. We have to hold the calcaneus and give posterior to anterior glide. And then we have the AP glide. So AP glide, we have to stabilize the posterior aspect of the talus. The first way space we have to keep are the anterior part of the inferior calcaneus and give anterior to posterior translation, AP glide. And then we have the lateral glide. For the lateral glide, we stabilize the lateral malleolus, and the heel of the palm is kept in the medial aspect of the calcaneus, and we are giving the glide lateral. And next, the medial glide. Medial glide is very, very useful. All the glides will be applied based on the requirement, but for the medial glide, you stabilize the medial aspect of the talus from the lateral aspect of the calcaneus and giving the glide from the lateral aspect medially. Now, let's analyze. When somebody has got a pronated foot or a flat foot, there will be a calcaneum valgum. So it has already gone laterally. So lateral glide. So what we can do is we can add the medial glide for that. So medial glide will be one very useful treatment technique for pronated foot, for the plantar fasciitis. So many times they will be happening together because there is excessive stretch to the plantar fascia. And these are the various gliding movements: the PA glide, AP glide, medial glide, lateral glide. Then we have the caudal and then cephalic glide. Caudal and cephalic. So these are the various glides of the subtalar joint. So I'll just focus it to the model. Yes. So first, once again, I'll show here the various glides. One is the PA glide, stabilizing the anterior part of the talus and holding the calcaneus, posterior to anterior glide. PA glide, AP glide, medial glide, lateral glide, cephaloid, and caudal. So these are the glides I'm going to demonstrate for the subtalar joint. So PA glide, stabilizing the anterior part of the talus here. Below the malleolus, malleoli, we can stabilize for the anterior part of the talus, holding the calcaneus. So now, obviously, when we move the calcaneus, the subtalar joint is getting mobilized. So we give the posterior to anterior glide. So grade 1, 2, 3, 4, AP glide. And then PA glide, we stabilize the posterior part of the talus. And then the first waist space is kept at the anterior part of the inferior calcaneus and giving the glide anterior to posterior. Grade 1, 2, 3, 4. And then we have the lateral glide. So for the lateral guide, as I just mentioned, for the lateral guide, see here, I have stabilized the lateral malleolus. And obviously, when we stabilize the lateral malleolus, the talus also gets stabilized. And from the medial aspect of the calcaneus, I'm giving the glide lateral. So that's how we can give the lateral glide, stabilizing the lateral malleolus. And from the medial aspect of the calcaneus, I'm giving the glide lateral. Grade 1, 2, 3, and then 4. And next, coming to the medial glide. For the medial glide, the subject is in side lying position. Come to side lying position. So for the medial glide, we stabilize for the uh, inferior to the medial malleolus. We'll stabilize the medial aspect of the talus, and then from the lateral aspect of the calcaneus, giving the glide medially. And as I said that this is very useful technique in case of a flat foot and pronated foot. Grade 1, 2, 3, 4. Right, come to supine line. Next is the caudad and cephalad for the subtalar joint. And hind foot bears a majority of about 60 to 70% of the load is taken by the hind foot. So hind foot is position is very, very important, because that is the first part of the foot positioning. And there are a lot of studies which have proven the connectivity of the foot with foot issues. When there is a pronated foot, it leads to the tibial internal rotation, it leads to the knee problem, and it leads to ultimately the femoral version problem, and then it leads to SI joint problems also. So there are studies which have identified the connectivity of the foot position or hind foot in inappropriate positioning. It can lead to the low back pain. So next is the caudad. You stabilize the talus and hold the calcaneus, and then the caudad glide. Grade 1, 2, 3, 4. And then the cephalic glide. So caudad glide whenever there is any foot arthritis is there, space reduction is there between the talus and calcaneus, that time you can give the caudad glide. And the cephalic glide, inferior part of the calcaneus, and we're giving the glide upwards, cephalic glide. When there is instability, along with the mobilization, we can often use the tapping techniques to provide the stabilization. Okay. So next, I'll discuss about, now we have done about the ankle joint, inferior tibiofibular joint. We are done with the subtalar joint. And next, coming to the mid-tarsals, the tarsal palpation and mid-tarsal joints, the talonavicular and the calcaneocuboid joint. But before that, I'll tell you how to palpate for the navicular bone, how to palpate for the cuboid, and how to palpate for the cuneiforms. So navicular bone, it's called as navicular because it is boat shaped. You can see the shape of the bone; it is boat shaped. So it is called as navicular. The word navicular comes from navi, and that means the boat. It's boat shaped bone. And this is the navicular tubercle. And sometimes you will come across patients, they complain that when they then in the foot they complain of some pain over here, and if you palpate, you can find sometimes some enthesopathy has happened, some kind of swelling has happened there, and it will be quite tender. Then what you can do, how can we palpate for the navicular bone, and what can we do for that kind of problem also, I'll tell you. So once I finish the mobilization, I'll be demonstrating some two important techniques of tapping, what we can use for the purpose of foot stability and to treat the foot dysfunction. Okay. Now from the medial malleolus, 1 inch inferior and 1 inch anterior. And if you are listening to my talk, and if your any one hand is free, then what you can do is you can just palpate your own foot and palpate the medial malleolus, and from there 1 inch inferior and 1 inch anterior, you can palpate for one elevated prominent area, and that is the navicular tubercle. And navicular tubercle, you can give the ventrodorsal glide. And let me tell you, these ventrodorsal glide techniques are very, very useful for the treatment of pronated foot and flat foot. Because in pronated foot, flat foot, the navicular is going for a ventral displacement, and it is going to touch sometimes the ground. It is going to be tender. It is going to be painful. So along with the mobilization, you can go for some tapping techniques, which I'll be just showing it towards the end of this presentation. So that's about the navicular 1 inch inferior, 1 inch anterior. You can palpate for the navicular tubercle and give ventrodorsal and dorsoventral glide. And next, the cuboid. The cuboid, it is present in the lateral aspect of the foot. You palpate the lateral aspect of the foot anteroposterior. You can palpate for one elevated area. If you palpate the lateral aspect of the foot anteroposterior, that is fifth metatarsal tubercle. Immediate posterior to that, you can find there is a gap. In this gap, you can palpate for the cuboid. It is called as cuboid because it is cube-shaped bone. So to that, sometimes there is cuboid displacement. Somebody is suddenly walking, some road construction work is going on, and sometimes we have faced that, suddenly you come across down the foot, some stone is there, foot goes for a twist, and with the twist, sometimes there can be ventral displacement. The displacement of navicular and cuboid are quite common. And in that time, we can give ventrodorsal glide, and we have a technique to manipulate the ventrodorsal, a thrust technique for the cuboid. That also I'll be showing that some of the thrust techniques. Yes. So now coming to just focus here, right? Okay, it's done. So medial malleolus, as I said, from the medial malleolus, 1 inch inferior and 1 inch anterior. We can we can palpate for the navicular tubercle, and this is the one. This is the one. 1 inch inferior, 1 inch anterior, and place the pulp of the thumb over there, and then give ventrodorsal glide. Grade 1, 2, 3, 4. And this is very, very useful because in pronated foot, the navicular is going to migrate ventrally. So we need to give the ventrodorsal mobilization. And then if you have got a high arched foot, that time you can give the dorsoventral technique. Dorsoventral technique, to be more specific, I can just show here. Dorsal aspect of the navicular bone, we are giving the glide ventrally. So grade 1, 2, 3, 4. If you have got a high arched foot, that time but majority of the people will be having a pronated or flat foot. In that case, you see that if navicular has gone ventrally, so the ventrodorsal gliding technique is more useful. The next, coming to the cuboid. So cuboid, as I just explained, foot lateral aspect anteroposterior, you can find for one prominent area, that is the fifth metatarsal tubercle. Immediate posterior, there is a gap, and there you can palpate for the cuboid. And cuboid usually go for ventral displacements. Although we have both the techniques, right? So lateral aspect of the foot, fifth metatarsal tubercle, immediate posterior, there is a gap. There I can palpate for the cuboid, and you can give the ventrodorsal glide, ventral path, grade 1, 2, 3, and 4. So you can see here, this is the fifth metatarsal tubercle. If there is a gap, ventrodorsal glide we can apply here, and then dorsoventral glide. Dorsoventral glide, from the dorsal aspect, we can give the ventral glide. Grade 1, 2, 3, 4. Right. And next, coming to the three cuneiforms. Now we have discussed the talus. Anterior part of the talus is more wider. We discussed about the epiglide, PA glide there. We discussed about the inferior tibiofibular joint mobilizations. We discussed about the navicular and the cuboid. Now coming to the three cuneiforms. So the first metatarsal base corresponds to medial cuneiform. Second metatarsal base corresponds to intermediate cuneiform. Third metatarsal base corresponds to lateral cuneiform. And fourth and fifth metatarsals corresponds to the cuboid. So we palpate the base of the first metatarsal, then we can palpate for the cuboid, and we can give the various mobilizations. Whenever there is foot stiffness, that time we can apply this technique. First metatarsal base corresponds to the medial cuneiform. Yes. And we can give the dorsoventral glide over there. This is the point. First metatarsal base, medial cuneiform. Second, intermediate. third, lateral. Fourth and fifth are corresponding to the cuboid. So giving the glides there, medial cuneiform, intermediate cuneiform. We can give primarily the dorsoventral glide because in the ventral aspect, we have a bulkier soft tissue and that is going to create a restriction for us to palpate the cuneiform's ventral aspect. So you see that third metatarsal base corresponds to the lateral cuneiform and give the glides grade 1, 2, 3, and then 4. And the next we have the intermetatarsal mobilizations. You know, the axis of the foot is passing through the second toe. So in the intermetatarsal joint, we have the ventrodorsal glide and dorsoventral glide, ventrodorsal and dorsoventral. And then we have the lateral glide and medial glide. Axis is there. So away from the axis, lateral glide and then medial glide. So these are the various glides for the intermetatarsal joints. So let me just show that. We can give the ventrodorsal and dorsoventral, and whichever part is more larger, that part we have to stabilize. So larger part has to be stabilized, and then the smaller part, suppose we are doing, for example, we are doing between the fourth and fifth metatarsal. So that means we are stabilizing the first, second, third, fourth metatarsals and mobilizing the fifth one. Now suppose we have to mobilize the between the first and second. So we have to stabilize the second, third, fourth, fifth, and mobilize the first one. So basically, we have to stabilize the larger part and mobilize the smaller portion. So ventrodorsal glide, grade 1, 2, 3, 4, and then dorsoventral glide. Ventrodorsal and dorsoventral. And axis of the foot is through the second toe, so we can give the lateral glide and the medial glide. So basically, whenever somebody has got some cross injuries, so foot crossed injury, some accident happened or some vehicle has gone on somebody's foot and there is a lot of stiffness, that time we can, or following any cast was applied for any lower extremity fracture, and after that, following the cast removal, we have got a lot of foot stiffness. That time we have to deal with all these individual joints. And next, coming to the metatarsophalangeal joint. The metatarsal head is convex and base of the phalanx is concave. So PIP and DIP is also following the same rule. The proximal articulating surfaces are convex and distal articulating surfaces are concave. So here the concave rule is applicable. So if we have to increase the flexion here, we have to give dorsoventral glide. For extension, ventrodorsal glide. Metatarsophalangeal joint. Metatarsal head, you can see here, is convex. So when a concave surface moves with respect to convex, the gliding moment happens in the same direction as the bone moment. So here you can see in flexion, this bone moment is going dorsal to ventral, so glide also will be dorsal to ventral. So we can give the dorsoventral glide and ventrodorsal glide. So PIP and DIP, interphalangeal joint, also same thing. So for flexion, dorsoventral glide, and for extension, ventrodorsal. So that is about in short, because food definitely is a very large topic, and then usually in my regular workshops about at least a 1.5 day, I cover it for the ankle and foot. But as we are doing a very brief presentation, so in a very short way, I just presented the various kind of mobilizations, what we do, various important ones, and then I'll show you some of the thrust techniques. Some of the thrust techniques, tibio-talar joint thrust. So that is again for dorsiflexion. I already showed you the various mobilizations in previous part of this particular lecture. And for dorsiflexion, we can give the various glide, and at the end you can give a thrust. For dorsiflexion, anterior to posterior thrust. For plantar flexion, posterior to anterior thrust. And for the mid-tarsal joints, for medial mid-tarsal joint, if you have got involvement, you can stabilize the calcaneus and then hold the forefoot, take the forefoot for eversion, go to the barrier, and you can give a thrust. So that is for the mid-tarsal joints, talonavicular and calcaneocuboid. You can go for this, stabilize the calcaneus and then forefoot eversion and go to the barrier and apply the thrust. And there is one thrust for the subtalar joint. Very useful thrust is there. So where gapping thrust for the subtalar joint. So what we do basically in that, we stabilize the lateral malleolus, hold the calcaneus, apply the traction, adduction, lateral glide, and thrust. So I'll show that. We stabilize the lateral malleolus so that the talus is stabilized. Hold the calcaneus, traction. Just come, we'll focus from here. Yes, correct. So traction, adduction, lateral glide, and thrust. Traction, adduction, lateral glide, and thrust. Because in case of calcaneum valgum, the lateral structures become tight. So when you give a traction, adduction, a lateral glide, obviously you are going to open up the structures which are tight in the lateral aspect, so that it is going to help in the treatment of pronated foot. So that is about the subtalar joint manipulation. And next I'll show you some of the tapping techniques. So just get me the pre-wrap, and so usually in the foot we are using the rigid tapes. You can see that this is the pre-wrap, and this is the brown tape, and this is Ethaflex. This is the Ethaflex, the material which is used inside the splints, and obviously it is quite safe to use it, because we need a good amount of support. So just come to supine lying position and slide. And yes, I told you about the lateral ligament injuries. So when we have the lateral ligament injury, the mechanism of injury is plantar flexion and inversion. That already I explained, that the foot is in the maximum loose back position because the anterior part of the talus is more wider. And so what we can do in that case is that you can cut this Ethaflex in a figure of a horseshoe shape manner, so that, because the prime purpose of taping is to support the structure which is incriminated or which is affected. And so we have to just take the pen, and you can just mark the malleolus. And once you have marked it, then you can just cut the Ethaflex, so that we can have a proper stability to the incriminated structure. And in the lateral ligament, we have the three components: anterior talofibular ligament, posterior talofibular ligament, and calcaneofibular ligament. It is the ATFL which is getting commonly affected. The anterior talofibular ligament, it is attached this way. See, this is the attachment, anterior talofibular ligament. So when it is going for plantar flexion inversion, there is maximum force which is coming to the ATFL, and that's how it goes for the involvement. And then you can find there is swelling appears, and then what you can do, as I told you, we can take the Ethaflex, and after that we have to stabilize with the pre-wraps. This is the pre-wrap, and so we put the Ethaflex and then support it with the pre-wrap. So you see that, so that from all the aspects of the ligament, we give the maximum support to the affected structure. And then we have to, on this pre-wrap, we have to apply the brown tape. We have to apply the rigid brown tape, because kinestio tape is there, but we can tear it off. And but ideally, if you have the scissors, you have to use the scissors. Otherwise, there will be fibrosis over a period of time. If you keep tearing the brown tape in your hand, that so you can just support it. You see that, if a structure, I have seen that people, sports people with immediate injuries, you do the tapping with proper support, and immediately they can go and play. Although if somebody is a star player and his or her presence matters a lot, that time we have to, although it is not properly advisable, but then if they are going to play anyway. So in that case, you can just support. And you saw that I use the horseshoe shape and then pre-wrap and the rigid brown tape. And then we can give one reinforcement towards the eversion. We can give the foot eversion because inversion is going to cause the strain. So with eversion we can give, and maybe another 1 or 2 stirrups we can apply. So that is for the lateral ligament injury. And if you have got a flat foot, what you can do, you can just support the arch, because arch support is very, very important. Because plantar fascia, the prime role is to support the foot and support the weight and right. So you can give some 2 to 3 reinforcements. You can see this, you can support the arch. Arch support itself, whenever you have got somebody with any kind of foot pain, you know, commonly that arch support itself is going to relieve the symptoms to quite a major chunk. And another thing is that, just bend it. In case of plantar fasciitis, that is one common condition what you come across. You palpate here, there will be severe tenderness. The central band of the plantar fascia, that is getting primarily affected. In the central band is attached to the anteromedial aspect of the calcaneus, and then there will be some pull over here, and there is tenderness coming over here. So in that case, you can give the hind foot mobilizations, because sometimes the restriction of hind foot creates extra stress to the plantar fascia. You can mobilize the hind foot, and especially the medial glide technique of the subtalar joint is going to be quite useful. And then you can give the support for the plantar fascia, like arch supports you can give, and that is obviously, along with that, you can go for the other ultrasound and other therapeutic approaches if it is available with you. That is absolutely fine. So I think these are the major aspects of ankle and foot dysfunctions what we come across as a physio. And I think I am done with my presentations, because and one more thing I'll just share with all the viewers, that this is one of my book on clinical symposia in manual therapy. And in this, I'll just there is a topic about 16 important topics I have written, and there is a topic about ankle and foot dysfunctions, where I've explained the anatomy biomechanics, where I've explained the various glides what I discussed in this particular talk, and the ventral dorsal glide, navicular drop, these things, and then tapping techniques for the navicular drop. Tapping techniques, I explained about the lateral ligament injury, and how you can palpate for the various navicular cuboid bones. And there is another book also I have just authored, that is about the manual therapy of the pelvic complex. And these 2 books are available through Amazon, Flipkart, and also through our website in mtfi.net. And many of my videos are also available in the YouTube. And if you are keen, then you can see them. And a lot of techniques are also there in our website, mtfi.net. You can see them, and if I've got any queries, you can just put it, and then I am sure that panelist Venu sir or moderator Dr. Nikita madam will be coordinating to facilitate those questions. And still, if you would have any issues, you are feel free to write to me by email, and you can get the email once you type it in the Google. So thank you very much. So Benu sir, Nikita madam, I am done. Apurv sir, I am done with my presentation.
Thank you very much, sir. Yeah, the session was very enlightening, very informative. Thank you very much, sir. Sir, we have a few questions.
Yes.
Sir, in MSK evaluation of ankle and foot, should we check the range of motion first or the muscle tightness? Which should we do first?
See, definitely, because what happens if whenever we go for the basic evaluation, suppose I go for the basic, materia medica examination protocol, So first, obviously comes the observation, and then when you go for the first comes in the sequence the active movements, then comes the passive movement. So obviously range of motion you are going to measure first, and tightness evaluation you are going to do in the passive movement assessment. But obviously it has to be done all together. We have to before we go ahead with the intervention, we have to go for the range of motion assessment, movement restriction, pattern of movement. We have to check for the capsular pattern if it is there. We have to check for the end fields, and obviously, so if I answer the specific in a very specific, the question is very specific. If I just answer that, first comes the range of motion, and next you have to do the length testing. But everything has to be done together.
Okay, sir. Okay, thank you. Sir, one more question.
Yes,
if there is a grade 1 sprain of ankle, so
yes.
can we give manual therapy?
Yes. We can give, no problem. Yes.
And one more question, sir. We learn different schools of thoughts like Kaltenborn,
Yes.
Mulligan's, Maitland's, and when it comes to the application, so what is the rationale?
Yes.
Which technique should we apply first?
You follow a biomechanical based approach. That is what I covered in my talk.
Okay.
Because every approach evolves from biomechanics, and every biomechanics evolves from anatomy. So it is all biomechanics, pathomechanics, and then, okay, I'll give a very simple example. Now, suppose we have got dorsiflexion restriction, correct? We can follow Maitland approach in that. We can follow Mulligan approach in that. You can follow Syriac's approach in that. You can follow Kaltenborn approach in that. That is nothing. There is no problem. But what you have to be very much sure is that you are going to give the anterior to posterior glide. Anterior posterior glide you can give, Maitland grade, or you can give the Kaltenborn concept, or you can give the Mulligan concept I just mentioned, that you give epiglide and facilitate the dorsiflexion movement. That is how you are going to blend, because no approach is going to contradict each other, because all the approaches are based with fundamental principle of biomechanics.
Yes, sir. That was a good answer, sir. Sir, finally, our audience would like to know your latest research work in ankle and foot.
Yeah. I think a lot of works are going on. So I think I have developed one new grading system called as Mohanty flat palpation grades. So
Yes.
that we have done some ultrasonographic analysis, and what I have observed is that is already published in my book, and some of the articles we have done. So inter and inter-rater reliability also we have completed. We are yet to publish it. In the meantime, we have done some ultrasonographic analysis of the various layers, and that is one work which will be applicable for the entire body. That is what I am doing, and still I think that the concept of science is so vast, and the manual therapy is so vast a subject that I think that the scientific community, we know maybe 4 to 5% of the scientific concept of manual therapy so far, and I am a very small fish in this in this vast researching community. So, but I and my team, we do our best to give something what we can to the great physiotherapy profession at large. Yes, sir.
Okay, thank you, sir. Finally, any take-home message for our students and audience?
Take-home message is that physiotherapy is one great profession, and personally, I feel very proud to be a physiotherapist, and I think we should invest our maximum time, energy, passion in this great field of physiotherapy to serve the humanity at large. So that is what, and I wish that everybody, this is a Navratri time. I wish that have a great Navratri time, and have a great Durgashtami, and have great Dasara, and may God bless each and every physio and every person in this earth. So thank you very much.
Thank you, sir. Happy Durgashtami to you also. And
yes.
Now I'll hand over the session to Nikita ma'am.
Yes. Thank you very much, sir.
Thank you, sir.
Thank you, sir. So as we learned from this session, the ankle and foot represents the most distal part of our lower extremity, as we all know as physiotherapists, and it functions together to make habitual bipedal stance and locomotion possible. I thank our speaker for today, Dr. Mohanty, for the inquisitive session on manual therapy techniques in ankle and foot dysfunctions. So thank you for piquing our interest in the evaluation and treatment and pointing out things which we normally miss out on during the clinical examination. Next, I would like to thank thank you, sir. So next, I would like to thank the driving force of our institute, our founder, President Dr. K.H. Sancheti, our ever-inspiring chairman, Dr. Parag Sancheti, and our dynamic executive director, Mrs. Manisha Sangvi, and our always encouraging principal, Dr. Vivek Kulkarni, for giving us the platform to perform and show many techniques, many other different subjects which we normally miss out on during our curriculum. I thank our PhysioTV team, Dr. Ashok Sham sir, Mr. Rahul Chaube, Dr. Apurva Shimpi, Dr. Neeraj Athavle, Dr. Manish Rai, Dr. Amruta Podar, and all other members of the PhysioTV team. Lastly, I express my gratitude to our attendees who have played a vital role for making the webinar successful, and look forward for your support in the upcoming webinars as well. Dr. Nikita signing off. Stay safe. Take care of yourself and your dear ones. Festival greetings to all.